Thanks very much, Marlies, and thanks everyone again for the opportunity to come to Vincenza and speak to you today. I think my talk is complementary a little bit to Ravi's talk. He certainly went through very nicely an overview of a lot of the indications for which CRRT can be used in a variety of clinical scenarios and settings. I'm going to talk a little bit about just timing, and I've split my talk kind of into two because I do have another presentation at 10 o'clock that talks a little bit more detail about some of the trials that have been published recently. So I have these disclosures if anyone wants to ask me about them later. But first thing I'd like to highlight, I think it's important, is that timing of initiation of dialysis therapy in our critically ill patients, or just in patients in general, is not a new question. This is something that has been sort of percolating in the literature for the last 50 years. And I don't think it's until the last 5 or 10 years that we've really started to generate new and higher quality evidence to help guide our clinical practice around when to ideally initiate patients onto renal replacement therapy. I think it's important for us to recognize as clinicians in critical care settings and acute kidney injury that we are actually utilizing more renal replacement therapy in our critically ill patients than we have been in the past. And these are data showing you trends in the utilization of renal replacement therapy, both from Canada and also from the United States. But there's similar data also from the United Kingdom and Australasia showing that of the patients who are being admitted to the intensive care unit now who develop acute kidney injury, we are actually utilizing more renal replacement therapy for these patients. And that may in part be related to changing demographics we see in our patients. They're older, they're burdened by more chronic kidney disease, they have more comorbidities, and just with advances in medical science in general, we're putting these patients through more advanced chemotherapies, advanced procedures for various things, cardiac surgery, etc. So these patients are sicker on average than perhaps they were 10 or 15 or 20 years ago. But needless to say, we're using more today. So it becomes important for us to ask ourselves, when should we be ideally initiating it? Now, if you go back to your classic nephrology textbooks, I'm sure some of the speakers today have written those chapters in those books for you, to say the least. This would be a list of sort of the emergent or urgent indications for initiation of renal replacement therapy. And this is very analogous to one of the slides that Ravi showed in his talk previously. I think none of us would disagree that if you're confronted with a critically ill patient who's got acute kidney injury and has these sort of evolving complications that are medically refractory, none of us would sort of hesitate to consider initiation of renal replacement therapy. But one of our challenges as clinicians in the ICU setting when patients have acute kidney injury is that these, in fact, life-threatening complications of acute kidney injury are less commonly encountered. So this is a study that we did in Canada in preparation for one of our timing trials that really tried to understand, what were the factors at the time of initiation of renal replacement therapy that seemed to provoke clinicians to start. And what we found was those classic life-threatening complications, such as hyperkalemia, such as severe acidemia, etc., were less commonly encountered, right? And this is important to recognize because in all likelihood, we are seeing CRRT, and as Ravi's nicely highlighted for us, often we're using renal replacement therapy, CRRT, in acute kidney injury to help support other organs. So it's often in the context of multi-organ dysfunction. These patients are on a ventilator, they may have some lung injury, these patients are on vasoactive support, they have some form of shock, they have a concomitant liver failure, etc. So these patients often have other indications beyond the classic that we commonly cite in textbooks and whatnot. But it is important to recognize, and this is a very nice retrospective study done by some colleagues in Brazil utilizing the MIMIC-2 database from Beth Israel Deaconess in Boston. But it really shows that there is some attributable hazard, if you like, some attributable harm to complications associated with acute kidney injury, particularly cumulative fluid accumulation and metabolic acidosis. These seem to be, independent of your severity of acute kidney injury, associated with a little incremental hazard for death. And that those patients who had these complications, if they were treated with renal replacement therapy, that did seem to mitigate that risk of death to some extent. So it's important to go back and maybe revisit what our clinical practice guidelines tell us about when is the optimal time to initiate renal replacement therapy. And in the 2012 iteration of KDIGO, there was really two statements made about when to start renal replacement therapy. The first was initiate renal replacement therapy emergently when life-threatening changes in fluid, electrolyte, or acid-base balance exist. I think that's a sensible statement. None of us would disagree with that per se, though it's not graded per se, and it's not based on sort of robust evidence from clinical trials. It's really a consensus of experts at the panel. The second statement was a little bit more vague, but also has sort of, in my view, content validity. Consider the broader clinical context, the presence of conditions that can be modified with renal replacement therapy, and trends in lab tests over time rather than a single isolated laboratory value of urea or creatinine when making the decision. Again, a sensible statement, again, not graded based on robust evidence from clinical trials. So it's likely in the next iteration of the clinical practice guidelines, which I believe are scheduled to begin next year, you'll see some modifications of these statements based on trials that have been published in the last few years. So what about starting? When do we start? Should we consider starting early, or can we watch and wait? And I think there are purported benefits for an earlier initiation of renal replacement therapy. I could make an argument to you that it would allow us to obtain better azotemic control. We could obtain better electrolyte, acid-base homeostasis. We could get on top of fluid balance and maintain fluid balance homeostasis much greater. We could prevent those complications from AKI even occurring. As Ravi had said before, some aspects of nutritional support can be enabled perhaps by renal replacement therapy if carefully prescribed. And then there is the question of immunomodulation. Can renal replacement therapy in fact modulate the immune system in inflamed states such as sepsis? Those are perhaps some of the purported benefits of getting on with it and starting early. But at the same token, there are risks associated with renal replacement therapy. And to be honest, it's a fairly invasive therapy to some extent, right? We have to put a dedicated line in. We do expose a patient's blood to an extracorporeal circuit. Of all the procedures that we do in critical care, that's fairly invasive, right? We often anticoagulate the extracorporeal circuit, and while we have protocols and it's reasonably safe, all are known to have some complications associated with them. There's the risk of micronutrient depletion, and we're actually not sure what the long-term implications of that may be. It does add bedside resources for our nurses and our ICU staff. And there is the plausible idea that, if we started too early, we might interrupt or disrupt the repair and recovery process within the kidney in and of itself. So ultimately, the balance of a decision to start renal replacement therapy is based on indications and the perception of whether there is going to be greater benefit than relative risk. Now, what do we do in clinical practice? When we ask clinicians, and there's been 3 surveys of practice that have been performed in the last few years, we ask clinicians, what do you do in clinical practice? And all of these surveys largely found the same thing. The decision to start is largely subjective, right? It's based on the spectrum of clinical information available to clinicians at the bedside at the time, but it's also based a little bit on our cognitive bias. And I think it's important to recognize that. Providers start when confronted with life-threatening complications. That's great. That makes sense. There's wide variation in the minimum severity of indications prompting initiation of renal replacement therapy. So again, that gets at large heterogeneity in practice. And then many factors seem to modify the decision: the age of the patient, their burden of comorbidity, their responsiveness to a diuretic challenge, how sick they are, and the prescribing service, the time of day, the day of the week. To be honest with you, I had a meeting with some nephrologists last week, and they overtly let slip that on a Sunday night at 4 a.m, they're not likely to come in and start a patient on renal replacement therapy. So let's be clear about our cognitive bias in this respect. There are lots of observational studies that have been published that have tried to give us some insights and to help guide our clinical practice. And unfortunately, a lot of these observational studies, and I'm guilty of publishing a couple of them too, are certainly highly susceptible to a variety of bias, right? They're all observational. Many are retrospective. Often there are secondary analyses from cohort studies or randomized trials. They often dichotomize patients into 2 groups based on some biochemical parameter. And I'm not clear whether the observational data to date can give us a clear sense about how we should initiate renal replacement therapy in our patients. There's been a virtual industry of systematic reviews as well that have looked at this issue, and they've pooled all the data, both from observational studies and from randomized controlled trials. And even though there's 5 or 6 or more published in the literature to date, to be honest with you, they largely conclude the same thing. And this systematic review, which is probably one of the most recent, concluded that based on their evidence synthesis, their early initiation of renal replacement therapy however defined by these studies, and let's be clear, it's variably defined. Early in one observational study is often late in another. But early initiation of renal replacement therapy in critically ill patients with acute kidney injury did not seem to confer survival benefit or reductions in resource utilization. So I would submit to you that the clinical dilemma we have as providers is that the optimal timing of initiation of renal replacement therapy is clinically uncertain. There's not a lot of consensus to guide our practice. There's clear evidence from surveys and observational data that we are widely variable in how we practice this issue when we start patients on renal replacement therapy. And I argue that this is an important knowledge to care gap. Now, given that there's a large variation in practice, this is an interesting study that was published last year, and it's really looking at, I think, the take-home message from this study is homogenizing practice to some extent and reducing unnecessary variation. So this was basically the implementation as a quality improvement project of a decision-making algorithm of when to initiate and discontinue renal replacement therapy. This was done at a single academic center in Boston, basically 176 patients and a single group of 9 nephrologists. So very small group of nephrologists who even within them had considerable variation in practice. And they basically implemented this decision support algorithm called SCAMP, or Standardized Clinical Assessment and Management Plan. And basically what it did was it looked at a variety of clinical factors and then made a recommendation to the clinicians about whether they should start renal replacement therapy or not. Interestingly enough, the SCAMP algorithm in these patients recommended it be initiated in 31% of the patients. What was interesting is that the clinicians didn't adhere to it 57% of the time. They basically said, nope, I disagree. I'm not going to initiate renal replacement therapy, even though the algorithm told me to. And that was largely driven by the clinician's perception that either they were going to recover kidney function very quickly, or in fact, they perceived it as futile, that this is not going to change the management, therefore I'm not going to provide it. What was interesting is that renal replacement therapy was not recommended in 69% of the time, and adherence was 98%. So there may be some bias in this perspective of this group of nephrologists that they're disinclined to provide renal replacement therapy in this context. I'm not sure. It's a single center nonetheless. But when they looked at it in a little bit more detail, they suggested that there was some homogenization of practice a little bit, and there was some evidence of some impact on patient survival, particularly amongst those that had low predicted mortality. So those that had low predicted mortality, if you followed the guideline or the clinical decision support algorithm, there was improvements in survival. Now, I think this has a number of caveats. It's highly susceptible to bias. It's a single center experience. But I think that the take-home message here is that it may improve, practice variability by reducing unnecessary initiation or not initiation of renal replacement therapy within a given practice. So this is something, in the absence of clear evidence, you could potentially implement to homogenize practice and improve the quality of initiation of renal replacement therapy care that you provide. Now, this is an interesting study that was published in Japan. It's about 350 patients, and it really looks at, the two cohorts of patients amongst a group that receive renal replacement therapy, who is least likely to benefit. And I think that's an important ask that we may have. We often will initiate therapy in the context of everything we're doing for critically ill patients. But what this study did was it isolated two cohorts of patients. One who recovered almost right away. Within 24 hours, these patients were off their CRRT. So you could make the argument, unless there was a clear metabolic life-threatening complication, it may have been sort of unnecessary initiation in the short term. And then, of course, there are those who died immediately within 24 or 48 hours. And it's very unlikely that renal replacement therapy in and of itself would have played a part in reducing the probability of death in these patients. Now, I'm not going to get into details in the clinical trials that have been published on this in the last couple of years, because I have that in a presentation in about another hour. But just going to drop this on you now to sort of give you a hint about what's coming. Two large clinical trials, to some extent, have been published in the last couple of years. The Akiki trial here that really randomized patients to early initiation versus delayed initiation of renal replacement therapy. These were all pretty sick, ventilated, vasoactive supported medical patients, really not showing any evidence of a difference in survival at 60 days. What's interesting is that mortality was pretty high, approaching 50% in both groups. That being said, there was a lower utilization of renal replacement therapy amongst patients who were initiated in a delayed strategy, probably because clinicians had the opportunity to either medically manage complications or have greater time and opportunity to see if recovery was in fact going to occur. Then the second was the Elaine trial that really looked at randomizing, again, patients to an early versus delayed strategy of initiation of renal replacement therapy in mostly surgical patients. And this, alternatively showed that there was a significant improvement in survival associated with early initiation of renal replacement therapy. And I'll get into that in a little detail later this morning. So some final thoughts for you. I think the decision to start renal replacement therapy is complex. It represents a significant escalation in our support of critically ill patients, and it can be influenced by a variety of factors, patient-specific factors, clinician-specific factors, and also factors that may be health system related to some extent. There's wide variation in practice, and I would encourage you all to look at the scope or the range in practice that occurs at your institutions. The issue of who and when and under what circumstances to ideally initiate is still evolving, but it does represent an important knowledge gap. And I think there's a role for additional clinical trials to help inform our clinical practice. So thanks very much.